Hi, this is Dana Resop. We're going to do head and neck point of care ultrasound talk today. This is supposed to be a mini talk and is not comprehensive. This is supposed to give you an idea of some of the cool things that you can do with ultrasound in your clinical practice. So we're going to talk about today how to scan the head and the neck, things that we might find in normal patients and things we might find in abnormal patients. First of all, let's talk about how we're going to do this. So you want to make sure that you use a high frequency probe. In the world of the emergency department, we usually have access to a linear probe and hopefully access to an endocavitary probe as well. Both of these are high frequency probes. The endocavitary probe obviously is a little bit different and better for internal ultrasounds than the linear probe. Just like everything else, you want to make sure that you get orthogonal views, so make sure you're seeing every structure in two different views. You can use Doppler in order to determine if a dark area is a vessel or if it's a fluid collection. And you want to make sure that this patient's head is nice and supported so that they're not having to use their muscles to push against your hand, because your hand's going to be anchored on their face in order to make sure this ultrasound probe is nice and steady and that you're not pressing too hard on inflamed areas. So we're going to talk about salivary glands, sinuses, and nasal bones, and then some deeper ultrasound of the tonsils and the vessels. The salivary glands that I ultrasound the most clinically are the parotid and the submandibular. The parotids are on the side, submandibular are right below the jaw. I don't find the lingular ultrasound to be as useful, mostly because these are deeper and they're not as affected as much. So let's start with the submandibular gland, because this is probably the one that I see problems with the most often. Patients often come in with a lot of swelling underneath their jaw and this discomfort that is difficult to determine what it is with no signs of cellulitis. If you're going to ultrasound it, just remember that your probe is upside down. So what you should see is here at the top of the screen, you'll see skin. Under that, you'll see some thin muscle and connective tissue layers. And then this is what a salivary gland looks like. So this is this sort of homogeneous isoechoic tissue that looks like it's kind of blobby. And sometimes you'll see a little duct go through it, so a little thin black tube. That's not uncommon to see the Wharton's duct of the submandibular gland. On this particular view, this is medial and this is going to be lateral. As we scan through this, you'll see the submandibular gland show up, a little bit of muscle underneath it. And then interestingly, deep to this is actually the floor of the mouth. So up here, we're seeing these little air pockets here. That's actually the saliva in the mouth, little air bubbles in there. So you can actually ultrasound up into the tongue in some of these patients. The submandibular gland, when it's normal, is going to be homogeneous, a little bit hyperechoic, and you may see some kind of hyperechoic lines with a little hypo or anechoic center, which is the duct. And you may also see some lymph nodes in the surrounding area. This is a little bit of a grainy picture, but we'll go through it. So here's a lymph node right here. And then over here we have the submandibular gland. So there's a couple shadows in here, makes it a little bit harder to identify things. But here we have a little circular duct coming right along here, which lines up with the Wharton's duct at the floor of the mouth. In an abnormal salivary gland, it usually gets enlarged, which is the easiest way to identify that it's inflamed, is that it's much larger than the other side, or that you typically see it. It will be more heterogeneous, and honestly, it looks a lot like soft tissue inflammation, like cellulitis, because you'll get these little wisps of fluid within the structures that you don't typically see. The ducts are often enlarged, because that's often the problem and the cause of the inflammation. So there's a duct right here, so it's a little bit more visible. On a physical exam, the Wharton's duct ends right here below the floor of the mouth. That's what these two little lines underneath the tongue are. In this particular patient, this is a clinical picture of a patient who has a stone that's trying to get out of the Wharton's duct. On this picture right here, this is that inflamed Wharton's duct, and you can see the little dilated ducts right here. There's a branch here and a branch here. They come together right here. You can sometimes identify this may be a stone right here. It's hard to tell in this still picture. And over here is an actual stone. So if you do see a stone in the duct, you actually can measurement and give that patient identification of what their problem is. Right here is another picture of a stone. Here's another picture of stone. This is a little bit of a higher frequency ultrasound probe than we typically have in the ER. Here you can see that duct with a little bit of pus in it. The most often salivary gland to get stones in it is going to be the submandibular, which happens much more often than the parotid and the sublingular. This is a nice normal looking parotid gland. So here is this like nice thin little parotid gland just overlying the normal tissue structures of the face. Here's the masseter muscle right here, which sort of wraps around the edge of the parotid gland. It's kind of right underneath the edge of that parotid. The parotid actually comes all the way down by the mandible. I had a patient when I was a fellow who had a picture that looked just like this. He had pus just draining out of the Stensen's duct on the edge of the buccal mucosa. This patient would have had the same ultrasound as we're seeing right here with this very dilated duct and this wide, sort of dilated or just enlarged parotid gland. Okay, you don't always see stones. Sometimes just infections can cause these dilated ducts. If you're not sure if it's a duct or not, you can always throw color on it and see if it's a vessel. So down here is a inflamed parotid that just is because of parotitis, and they had big lines in there, but they were all just blood vessels. Versus this up here is a duct. Here's another example of a parotid gland with a problem. This is a patient who was transferred to us for ENT for a very sad parotid gland. They had a dilated duct, and the reason why is because they had a very large stone. So although stones are not as likely in the parotid gland, they can occur. And when they occur, they can be just as uncomfortable in this gland as they are in the submandibular gland. Down here, you can actually measure it. You can measure the duct itself. This duct was 9 centimeters. And down here, you can, on top of my little play bars here, you can see the stone, and it's measured out as 0.9 centimeters. So other things we can ultrasound in the face that can be useful are the sinuses and nasal bones. So if you work in an emergency department where you have a large number of people coming in for primary complaints, you may have some utility for this ultrasound. This is sinus ultrasound, and you can see through this very thin bone of the maxillary sinus fairly easy with an ultrasound probe. You do want to make sure that that patient is sitting as upright as possible, because what you're trying to do is get that fluid to make contact to the sinus bone so that you can see into the deeper structure of the sinus. Some of this information, these pictures are from an internal medicine clinic where they did this for several years and found out that they decreased their antibiotic usage by about 50%. Granted, in that case, most of the sonographers were providers who had a fair amount of sinus experience, but they had very few bounce backs or problems with patients being incorrectly diagnosed. We'll start with abnormal down here. So in the transverse view, the sinus has this kind of V shape in the back, and the back of the wall should always be at least 3.5 centimeters. Okay, and this is the sagittal view, so now this indicator is up towards the patient's head or their eyebrow, and this is down towards their jaw. And in this view, the back of the maxillary wall is this nice straight line. Once again, it's still about 3.5 centimeters back. This is, up here, pictures of normal sinuses. So a normal sinus is what it should look like is, honestly, it should look like lung. Okay, because you should see these air lines, the A lines that you see along, just like you do on your lung ultrasound of that artifact from the sound waves bouncing back and forth and having reverberation. This picture here is an example of what you'll sometimes see with that artifact is a false positive, but when they measured this, they found out that this line right here was less than 3.5 centimeters, so that better identifies it as an artifact. If this was actually the posterior wall of the sinus, it would be back here. The other place that this is starting to be used fairly frequently is in intensive care units, because these are more frequently having ultrasound availability, and these are patients who are at high risk of sinusitis and often come up with fevers of unknown origin. So these are pictures of sinus infections in patients who are ventilated. Here is a picture of a partially occluded sinus. Right here, you can see it on CT scan. When they had this patient sitting up, they could see a partial fluid layer in the sinus. So you can see kind of partially down here. They can see all the way to the back of the sinus. And then up here, this is where the air level is on this particular patient. Here is a patient who has a fully socked in, fluid-filled sinus. The sensitivity for this isn't awesome. It's about 70 to 75%. The specificity is fairly decent, but at least saves these patients having to go to a CT scanner and helps in patients who you've got some clinical uncertainty about their diagnosis. One place where this has been found to be useful in the last couple of years is in COVID, because this saves trying to take these infected COVID patients. Some of them are very, very ill, and you can diagnose sinusitis in these patients without having to transfer them to other places in the hospital and potentially spreading COVID. Another place we can use point-of-care ultrasound in the clinical spectrum is in patients who have been minding their own business but have had trauma. So patients who you're concerned about may have nasal spine fractures, but it's clinically not clear. You can use point-of-care ultrasound, especially if they got a lot of swelling in their nose. Sometimes it's hard to tell if there's actually a fracture under there or if they just have a lot of bruising. What you do is you want to ultrasound both the lateral sides on the right and the left, as well as the midline spine. Basically, you're going to be looking at that whole area. This is mostly a long axis view, but if you find any findings, you do want to confirm them in short axis. So this is a long axis view of a fracture here along the side of the lateral wall. You can see there's a little bit of a comminuted section right here, and then the edge here. The sensitivity for this on ultrasound was 70 to 80% in people who use it fairly commonly, which is better than plain films, but not as good as CAT scan, just like most things in ultrasound. There are a couple examples of fractures in different places. Here's a midline spine fracture, lateral wall fracture, a side fracture, or if they're actually able to see that kind of septal fracture in the middle. Looking a little bit deeper, the ultrasound that you guys are probably most comfortable with up in the head and the neck is going to be the tonsils, and we'll also talk about vessels and lymph nodes. So peritonsillar abscess are fairly commonly cited as a use for ultrasound. This is a tongue depressor right here, looking at this big swollen peritonsillar area with a tonsil right next to it. Here's somebody doing that same view, but with a intercavitary probe. You'll notice right here, this is a tonsil right here. The tonsil is a little bit inflamed, but what we're seeing right next to it is this very large fluid collection right here. This ultrasound can be used in a dynamic setting where you're trying to use the ultrasound and also guide the needle at the same time. But I would probably recommend for most patients, because most patients aren't that comfortable with having that many things in their mouth, no matter how numb you get them, is to just go ahead and use this as static guidance. So go ahead and use your ultrasound probe. I would recommend in the transverse view, kind of slide up and down past that fluid collection, and then determine where exactly the biggest fluid collection is when you're looking at the patient's mouth and correlating it with what you're seeing on the ultrasound screen. Then you can take that ultrasound probe out and go ahead and drain the abscess. One thing to be aware of, though, is that the tonsils can look fairly hypoechoic when they get inflamed. A normal tonsil is kind of hypoechoic. When they get inflamed, they can sometimes have a striated, kind of bright hyperechoic little lines in them appearance. So you want to compare the two different sides, and if you have concern for bilateral peritonsillar abscess, just have some high clinical suspicion for that, because that can be a reason why we miss these. So here's a normal tonsil on this patient's right-hand side. This is the patient's left-hand side over here. As you can see, this is a very tiny little, like maybe a half of a centimeter little peritonsillar abscess right here. Clinically, you can decide whether or not this patient needs to have an attempt at draining this, or if you feel more comfortable just starting them on antibiotics and having good follow-up. One other thing you can use this for back here is you can actually look for blood vessels and see how far you can go with your needle before you start to run into vascular structures. And you can go ahead and throw color back here to see which of these hypoechoic lines back here are actually vascular. If you can't tell the difference between a really dark peritonsillar area that's just an inflamed tonsillitis versus a actual abscess, then you can go ahead and use color. So this is a study that showed that the color flow, just using regular color flow on inflamed tonsils, was helping people determine that this was not a complex abscess, but was actually a tonsil. This is another example of a bunch of emergency medicine residents who were draining peritonsillar abscesses. This is a picture from their study, but basically what they found is that with ultrasound guidance, they had a 100% success rate, and they had an average of 1.4, so 1.5 tries per patient in order to get that successful drainage. And in the landmark group, they only had about 50% success rate, with those patients having to be consulted with ENT for their final drainage. This picture also shows you an example of finding the carotid back here and then determining how far you need to avoid going in order to hit your vascular structure back here, which obviously we worry about. If you have a patient who has trismus and is unable to open their jaw and you want a quick answer as to whether or not they have an abscess, you can use what's called a transcutaneous approach. Basically, this is just like looking at the submandibular gland, but you want to make sure that your depth is deep enough, and then just keep on scanning posteriorly. So take that probe, put it under the angle of the jaw, and then just start to tilt it back. What you should see is you should see the edge of the tongue in the near field, and then you should be able to follow that back until you get to the point where you'll see the tonsil behind it. So this is a peritonsillar abscess in an autistic autistic child who would not open their mouth, and so they had a ultrasound diagnosis of a peritonsillar abscess on this transcutaneous view. Last thing to look at is vessels and nodes. Blood vessels you guys are probably pretty comfortable with because of IJ vessel, the catheter access that we use all the time. So this is a patient who has a IJ clot, probably because of some previous access. I think this patient was recently discharged from the hospital and they have a little bit of a clot blowing around in here. This can be clinically significant, one, if you're trying to put a catheter back into this IJ, but also this is a case study over here on the right. This is an image from a case study in 2007 where they ran across a patient with Lemire syndrome on their bedside ultrasound while they were evaluating this patient's neck and head swelling that they had and fairly ill picture. So this is a patient who has a infected thrombophlebitis of the internal jugular vein. The faster these patients get started on antibiotics, the better their chances are of getting better. This diagnosis has a high mortality rate. I am personally really bad at estimating jugular venous pressures, and so I was happy to hear that I can actually use ultrasound for this process because I know I can do this. I'm not always sure that I can find an IJ, especially in our bigger patients, clinically at the bedside. So what you do is you have the patient sit at a 30 to 40 degree angle, just like we do for physical exam JVPs. And then you go ahead and take your ultrasound probe and you find the internal jugular vein. So this is a picture of them kind of looking at this internal jugular vein and find the spot where it starts to collapse down. And then you measure from the spot where that IJ is collapsing to the sternal notch, and you add 5 centimeters to that, just like you do with physical exam, and that is your JVP. I personally think it's a little bit easier to identify that IJ and then find that area where it starts to taper down in long axis. So this is an example of that. Here we are looking at the IJ, and here it is. They're sliding the probe back and forth a little bit just to make sure that they haven't just kind of fallen off the IJ. This right here is the area where that IJ is tapering. So you look at where this lines up with the probe on the patient's skin, and then you do this same measurement where you're measuring from the edge of the probe down to the sternal notch. Just make sure that you're actually, in this view, you want to be measuring from like the middle of the probe, right about here, and not from the lower edge or the upper edge, because then you'll be off from your estimation. Last but not least, if you're going to be ultrasounding in the neck, you're going to run into lymph nodes, so it's helpful to be able to identify what they're supposed to look like. They look like little black ovals with little bright centers. So they should be ellipsoid, hypoechoic. Sometimes when they get inflamed, they look anechoic, and then they should always have this little hyperechoic hilum. So this is a picture of, there's a submandibular gland that kind of jumps in on the side over here, but over here is a happy little nice normal looking lymph node over here with this little echogenic center. Sometimes when these get inflamed, it's fairly hard to tell that they're not just a big abscess with kind of a complex center. You can always use compression on them to see if that complex center moves around. But the other thing you do is you can just throw color on them. If that patient has an inflamed or an infected lymph node, then their color flow should be fairly obvious when you put that color Doppler on. So the moral of the story is you can ultrasound anything, or at least try. If you run into any problems, remember this is not one of the typical places we're ultrasounding around, so you always have availability of confirmatory studies or applying your clinical story. Thanks for your attention.